Hey everybody, it's Dr. Wood, and today we're talking about Chapter 16. We're talking about immunizations and the immune system. Now, keep in mind, if you're taking like an immunology class or anything like that, that's probably going to be way more advanced than what we're talking about here. I just want to talk about the immune system in terms of how drugs are going to be interacting with them, with a heavy emphasis on things like vaccines. But at a bare minimum, antibodies are typically things that our bodies produce. They are proteins, and they're kind of our body's defense against invaders. So they'll be able to identify things you may have some immunity against, they'll bind to it, and then cause things like the rest of your immune system to activate and then neutralize them. Okay, immunity just means you have protection against a particular disease, right? And this is very selective. Could be down to the individual strain of virus, like influenza. It could be disease state-wide, like measles or mumps, something like that. And basically, an antigen is any kind of foreign substance that your body is reacting to. So antigens may be foreign proteins, it could be a virus, it could be a drug potentially, right? Anything your body's having that reaction to could be an antigen. So there's kind of two main varieties of immunity we're going to talk about. There's what we call inborn or innate immunity, and this is typically genetically conferred. These are going to be things like your skin is a big form of immunity to keep stuff out, your GI tract, your stomach being very acidic is another one, and then certain disease states we just have some natural immunity against, right? Acquired immunity is going to be what we're more focusing on, and this is going to be resulting from the introduction of antigens into the body that will then trigger our body to produce antibodies. Okay, so antigens will stimulate the antibody production, and then once that occurs, we'll have these memory cells that are able to reproduce that effect should the antigen come back, and thus we are immune to that. And so there's two main varieties of ways we can do that, either artificially, due to either vaccines or toxoids being received, or we can have it naturally occur just by natural exposure to the pathogens or to the disease process itself. So it's just like either getting a varicella vaccine, and that way you're protected against chickenpox, or just getting chickenpox itself makes you immune to it in the future. So again, just a picture showing you this where we have natural immunity where patients will contract the disease unless they will produce memory cells that will then protect them in the future. Or also there's ways what we call passive immunity, and this is actually where patients are receiving the antibodies from some other source. And the most common thing we think about is going to be fetuses who are actually getting antibodies from the mom in utero, or after they're born, they can actually get it through the breast milk once they're a newborn, and that will leave them protected for some period of time, usually about a year or so. A lot of the maternal antibodies will keep them protected as if they're being breastfed. So in terms of artificial immunity, this is where we're going to see patients either receiving a vaccination, and that'll help to produce some memory cells, or you can have another passive form of immunity where maybe they're receiving antibodies from an exogenous source, right? So we can give immune globulin, we can give antibodies that may neutralize certain disease states. And so this is less common, but certainly the artificial form here, the artificial active form, is probably the most common thing we're going to talk about here. So, as I mentioned, naturally acquired passive immunity is typically, you think about mother to child. Note here that this does not last forever. This is a temporary protection, mainly because while the patient has the antibodies floating around, they can't produce it themselves. And so this is a very short, sort of fleeting sort of immunity. Usually for infants, for instance, it goes away by the time the patient's about a year old or so. However, from artificially acquired forms like immunizations from a vaccine, again, this is typically introduced by using a weakened form or an attenuated form of a virus, or maybe just a killed form of it, things like that, or potentially even a subunit of the virus or bacteria. And then that allows the patient to respond to it to produce their own antibodies without getting seriously ill themselves, right? So that's the benefit. You kind of get the benefit of immunity without getting the illness yourself. And so looking at artificial passive immunity, this is where we would be providing the patient with antibodies from another source. Again, this is very similar to an infant getting it from the mom. It's immediate, but it's short-lived because the patient's not producing it themselves. And so this can either come in the source of things like immune globulins we can administer. Basically, if you were to ever donate plasma, you're donating your immune globulins to potentially give to someone else. Or we actually have anti-serum, which are antibodies to a specific antigen. Usually we're going to get this derived from animals. And so, for instance, in my line of work in toxicology, the most common thing I run into is if someone gets bit by a snake, we actually have antivenom that is basically just antibodies that have been derived from either sheep or horses. Basically, the sheep or the horses were hyper-immunized against the venom, and then we take the antibodies that they produce, inject into the patient, and then it neutralizes the snake's venom. So vaccines have had a dramatic effect on in terms of disease incidence in populations, because they will dramatically reduce those rates. They will protect huge swaths of the population. There's even things like herd immunity, where even people who don't get vaccinated can still be potentially protected if enough people around them are all vaccinated. And so the vaccines themselves are typically going to be suspensions of the microorganisms, either a portion of it, a dead version, or a live weakened version, that will cause that immune response, that will establish that resistance there. So as I mentioned, it can either be killed, where it's the whole microbe itself, like pertussis or rabies, or it could be a live attenuated form, so just a weakened formulation of the same virus. Something like polio or MMR would be a good example of that. And MMR just stands for measles, mumps, and rubella. Another forms you may see would be a toxoid. This is actually where the body's producing a reaction against a specific toxin that the bacteria may be producing there. So it's one thing that can cause immunization. Or again, as I mentioned, immune globulins. This is going to be short acting, but we're providing blood products that have the disease-specific antibodies against whatever you're trying to treat there. And then antitoxins would be sort of short-acting formulations or antibodies that are produced against a specific toxin. Again, they'll be able to neutralize that toxin, but they're not going to be a permanent sort of thing. So sometimes we use this for short-term prophylaxis, or for patients that may be at big risk for being in contact with one of these disease states. So who should be immunized? The short answer is pretty much everybody, right? We think about adolescents who are maybe at risk for developing certain types of infections. So especially if you think about like students going away to college dorms, you're around a whole bunch of new people, a whole bunch of new disease states potentially. That's why we like to have them being immunized. New parents, mainly because if they're going to be around infants don't really have a very good immune system, so you want to protect them. The elderly as well are going to have sort of a diminished immune system as time goes on, and so we want to protect them from getting certain disease states. And then anyone with chronic illness, either kidney disease, diabetes, HIV, they're all going to be relatively immunosuppressed, and thus they may not be able to fight off infection as well as healthy patients would. And then obviously any kind of healthcare workers, this is another really big concern as well, since you're around people who may have these diseases, and not only do you not want to get it, but you also don't want to spread it off to someone else, another patient you may be working with. Things like influenza, things like hepatitis B, things like that are really big things we worry about with healthcare workers. And sometimes what we can do to test to see if someone has good immunity is by doing antibody titers. And so frequently if you go to work in a hospital, they may actually go ahead and do things like hepatitis B titers to make sure that you have a good response should you be exposed to that antigen again. And if not, what they'll end up doing is called a booster, where basically they can try to re-challenge the immune system unless you're going to be able to produce more antibodies against that in the future. So that's where a booster shot comes from. Now, live vaccines should not be given to every type of patient. So, for instance, anyone who is immunocompromised, meaning they cannot produce a good immune response themselves. So, if they're receiving steroids or radiation or chemotherapy, they are not going to be good candidates for getting live vaccines. Patients with certain types of infections should also not receive live vaccines, or if they've had a prior reaction to a vaccine, so maybe anaphylaxis or a seizure, they would not be a good candidate there. And another big thing you always want to check for certain patients and certain vaccines is, do they have a reaction to eggs? Because some of them are actually made with eggs, and they can have a cross-reactivity, and they can have an allergy. Now, mild reactions to immunizations are fairly common. So if you imagine you're giving something that is trying to stimulate your immune system, and so your body's going to act the same way. So it's a very mild form, but you may see some inflammation due to that. So I always hear people say, oh, whenever I get the flu shot, I always get the flu. Well, you didn't really get the flu because the flu that you got is probably a very weakened form. It's probably going to be something that is either dead or very weakened, right? What happens though is your body's still having a mild immune response to that. So you can see things like a mild fever, you can see rash or soreness, but it's not going to be as severe as it would be if you got the actual full-blown disease itself. So it's one thing, it's a good counseling point for your patients. Is like, yeah, you may feel a little bit of an issue here, and maybe take some Tylenol to help deal with the fever, but for the most part, it's not going to be nearly as severe as the actual disease itself. Rarely, though, you can see some patients can develop, and this is extremely rare, like, very, very low incidence of this, but anaphylaxis is one. This is why you monitor patients shortly after you give them a vaccine. Thrombocytopenia, teratogenicity in pregnancy, these are all rare things, Probably the most common of the bunch would be anaphylaxis, but even that is exceedingly rare. One thing you always think about as well is if you have a patient who may be complaining of paresthesias or pins and needles in their maybe hands or feet, that could be a sign of something like Guillain-Barré syndrome. This has occurred with certain vaccines in the past, and so this would be, if they've had that, it would be another contraindication from them receiving a vaccine in the future. So documentation is a really important thing whenever giving an immunization, and so a lot of this is due to the National Childhood Vaccine Act that occurred. And basically what it means is that anytime someone's getting a vaccine, the parent or guardian or the patient themselves need to be provided with a copy of the Vaccine Information Statement, or VIS. If you've ever gotten a vaccine, you've probably gotten the VIS, even if you don't realize it. It's usually kept with all the other paperwork that you would have gotten from the clinic or wherever. And so what the documentation has to include is the date they received it, the type of vaccine they got, the route it was administered, and the site. It needs to include the vaccine type, manufacturer, lot, and expiration date in case there's anything wrong with that batch. And then it includes who actually is giving the vaccine, and then that they delivered the VIS. Again, that's by law, they have to receive that, and the fact that consent was given, right? So if a patient says, I don't want to get a vaccine, you can't force them to get it. So consent has to be documented. And here's some examples of different types of vaccines that we may give to induce an artificial active immunity. A lot of these are going to be given during childhood, during the first few years of life. And again, you could memorize this list if you wanted to, but you probably don't need to memorize it specifically for my class or in practice most of the time, because you can look up this information. So just for your purposes, so you know, the CDC, or the Center for Disease Control, is actually the best resource for knowing when and who to give vaccines to. Basically, they have all the information. They update it every single year in January on who needs to get what vaccines, when they should receive it, etc. Keep in mind, a lot of these do require repeated doses. So by re-challenging the immune system every few weeks, you can find that it will allow for a better, more durable response, meaning you stay immune for a longer period of time. And that's why you end up seeing that patients will have to get, shots at, say, 2 months, 4 months, 6 months, and then maybe a year and a half later, things like that. A lot of it has to do in order to keep a good, durable response to those immunizations. Now, in terms of administration and routes, for the most part, majority of your immunizations are either going to be given intramuscularly or they may be given subcutaneously. Occasionally, though, we may actually be able to give some intranasal formulations. So, for instance, some flu vaccines can be given intranasally, and then very rarely may receive one orally. Most times this is going to be for infants. This is actually going to be against the rotavirus. So have an oral formulation that's available for that. Now, agents used for passive immunity, very frequently these are antibodies that are donated from people who are donating plasma. And again, this provides a nice protection immediately. With the other vaccines we've talked about, basically it takes time for your body to actually mount a response against that. So they're not immediate, but certainly within a few weeks to months, you're going to be protected. If they're getting immune globulins, they're protected immediately, which is great. But keep in mind, once the body gets rid of those immune globulins, that protection goes away. So it's really only for a short period of time that they're protected. And so here's an example of a specific immune globulin we would give to patients. Here's one called Rogam. This is a common one that patients would receive during pregnancy, so it's very frequently given to female patients. Basically, this would be, I'm sure you're familiar with blood types. You can either be, say, O positive or O negative. That positive or negative is this Rh factor. And so there's a disease state called basically hemolytic disease of infants, where if you have a pregnant patient who is Rh negative, so she has, say, O negative blood, and she becomes impregnated by someone who has positive blood, and the baby's positive, well, the mom could potentially form antibodies and actually attack that baby. Maybe not the first baby, but perhaps with the second pregnancy, they can actually go and attack all the red blood cells in that baby, leading to potential fetal demise. And so what we can actually do is we can give the mom, we can give her Rogam, and that actually will help to neutralize any of these antibodies and prevent her from having a reaction to the baby, right? And so, for instance, my wife, when we had our 2 children, she got Rogam both times because while my wife is Rh negative, I'm actually Rh positive. And so because of that, that helps to protect her and protects the babies as well. And so not every patient is going to receive every single vaccine. Here's some examples of ones that would only be given for certain purposes, right, or certain unique circumstances. And a lot of these have to do with, have you been exposed to something, or are you likely to be exposed to something and need to have immunization against that? So, for example, if you don't live in an area that's a high risk for cholera, you probably don't need the cholera vaccine. Rabies is another one that we think about quite frequently here in the U.S. because we have some animals that may be have rabies, and you may need to give your patient some immunization against that. So for instance, if a patient is ever bitten by a bat, or for instance a raccoon or something, they could have rabies, right? And so you want to go ahead and protect them by giving them immunization against that. So again, there's lots of different varieties here. You don't have to memorize all of these, but just know that certain patients will need them for very specific circumstances. And keep in mind, we can also help to suppress the immune system, and this is frequently things we'll do if you have a patient who has like an organ transplant, because anytime you introduce a new organ into a patient, that can act as an antigen. And so in order to prevent patients from rejecting their organs, we actually will give them immunosuppressants. And so just know that the biggest risk you're going to see with these drugs is one, infection, and also you can actually see them depressing the blood cells and depressing the bone marrow, leading them to have a poor immune system and may not be able to fight off infection. Not only that, but the agents can also be what they call mutagenic, teratogenic, or carcinogenic. So there's some risk that they can cause mutations or cause cancer, or in potentially for pregnant patients, they can actually cause damaging effects to the fetus. So very frequently these drugs that are immunosuppressants will be contraindicated from being given to patients who are pregnant. And in some cases, we can actually give immunostimulants. And so most frequently, you'll see this using cancer, where we can actually stimulate the host immune system to fight off cancerous cells. And so an example of this would be like alpha interferon or proleukin. Again, by stimulating the immune system, you can also cause a lot of reactions that look like the patient's having an infection, since their white count or their white cells are overstimulated, so they can cause fever, myalgias, and all kinds of things like that. So not used too commonly, but some patients with cancer will end up getting these drugs. So that's it for this section. If you have any questions, let me know, and I'll talk to you soon. Thanks a lot. Bye.